Hello, my name is Max Schaefer. I'm attending anesthesiologist and the director of thoracic anesthesia at the Department of Anesthesia at Beth Deaconess Medical Center in Boston. I'm also the director of our anesthesia research program, the Center for Anesthesia Research Excellence. And I'm very happy to give this virtual lecture here on high-frequency jet ventilation in the operating room and how we use it in our institution, and maybe also some data that we have gathered. So yeah, it's a great honor to speak. I have 25 minutes. I'm just going to jump right in. What I'm going to talk about today are some technical aspects about high-frequency jet ventilation, maybe some of the physiological backgrounds, and then how we use it for elective procedures at our institution. And I will also touch a little bit on the physiological aspects and the safety of prolonged high-frequency jet ventilation and try to focus on practical aspects. So when did jet ventilation originate? So Henderson and colleagues already in 1915 observed that there can be gas exchange in humans or in mammals that is sufficient to support life, even when the tidal volume is lower than dead space. And this is as you can hear, I'm originally from Germany, so it's a German publication. I'm not going to translate this now, but there was one of the first publications on this by Mehta and Sanders. And they reported here a new technique to facilitate bronchoscopy. And this is often how we still use jet ventilation even up to these days. So gas exchange when tidal volume is less than dead space, is that magic? How does that even work? So what we teach our residents and our medical students is that one of the most important physiological backgrounds to consider when using jet ventilation is the Venturi effect. The Venturi effect basically describes entrainment of ambient gas when air flows through basically or is accelerated at higher speeds and flows through narrowing in the airway. So you can see here on the left side you have a velocity of the gas, and at a constant gas volume and gas flow, through a stenosis, the velocity is increased. And this will increase in velocity reduces the pressure. And wherever pressure is reduced, ambient gas, ambient air is entrained. And this is basically how jet ventilation works. So even if you do a lower volume, entrainment of gas increases your tidal volume and increases the volume of the air that you're supplementing. That also means it mixes your applied gas. And even if you're ventilating at 100% inspiration oxygen fraction, usually entrainment of ambient air will decrease your FiO2. Unless your ambient air is 100% FiO2, of course. So the Venturi effect is one of the most central effects of how jet ventilation works. There are other effects that have been discussed, and they are all not so straightforward to really prove them, or they might sometimes play more or less a role depending on the clinical scenario. There's, for example, Taylor dispersion and convective dispersion, which basically means that the gas is dispersed through turbulences into the distal parts of the airways and into the alveoli. Cardiogenic mixing, which basically is facilitated through pumping of the heart and compressing the airways and decompressing them, and thereby kind of providing circulation through this rhythmic repetitive compression decompression of the airways. There's Pendelluft, which describes intrapulmonary movement of air from more overdistended or more ventilated to less ventilated areas, and bulk flow, which basically means that the air is being pushed in with every subsequent breath until basically the applied tidal volume ultimately reaches the distal airways and the alveoli with more subsequent inspiratory cycles. So they all play a role, and in the end it's very hard to determine which of these effects are responsible for maintaining oxygenation in your individual patient, or which is the most important one. But clinically, it also doesn't matter. We know that it works, and this is how it's very often in medicine. We do know that it works. We have some basic physiological concept, but in the individual patient, there are always a lot of competing factors and things to consider. So why do we do jet ventilation at all? Why don't we just ventilate our patients like we do with the standard tidal volume, standard mechanical ventilation? So there are some surgeries where we need to facilitate access and exposure, and these are predominantly around the larynx and surgery in the vocal cords. You can see on the left side, this is an image that any anesthesiologist has seen 100,000 times in their career. You see exposed vocal cords, and when we place a tube through them, an endotracheal tube, standard size, they're often obstructed. You can use microlaryngoscopy tubes that might allow a little bit better visualization because they're just smaller. They have a smaller outer diameter, but in the end, sometimes that's even too much. And then you can either use a Handsucker tube that's on the right side. So this is the distal part of the Handsucker tube that has this little spring to keep it in place, and you would still place it through the vocal cords into the trachea, or you don't use a tube at all. And you, what we sometimes do, and I'll show this in a later slide, we'll connect jet ventilation to a suspension laryngoscope, and then you facilitate airway exchange even without putting anything through the vocal cords. Another very important aspect is that you can also minimize movement of any structures that are in the mediastinum or above or even below the diaphragm. And that's become one of the most important considerations when we use it these days, especially in our electrophysiological department. And I will actually detail on this a little bit later. That's important for our arrhythmia ablations. So ablations of atrial fibrillation, which we also call pulmonary vein isolations, because that's what they do. They basically electrically isolate the pulmonary veins, and the success rates are much better with minimal movement. And I'll have some data on this later. And this is where jet ventilation comes into play, because it facilitates minimization of movement of intramediastinal structures. So overall indications, I briefly mentioned rigid bronchoscopy is certainly one of the most common indications when our surgeons or our pulmonologists conduct procedures in the upper airways, sorry, in the trachea or the main stem bronchi using rigid bronchoscopy. This is usually where we connect jet ventilation. Then any airway invading tumor, those are very individual cases. Jet ventilation is certainly helpful. Resections of the trachea or the carina. Jet ventilation does have an important role still if you are used to it and if you have protocols for this in your clinic and cannot ventilate in intubate situations. I'm not going to touch this too much today because of the limited time. There's the potential to ventilate the non-dependent lung, so the non-ventilated lung in doing one lung ventilation and still avoid basically collapse of that lung while allowing for some airflow into that lung. And then catheter ablation procedures. I briefly touched our EP procedures, electrophysiological procedures, the atrial fibrillation procedures. Jet ventilation can be used in patients that have a bronchopleural fistula, where conventional mechanical ventilation would create too much flow through that fistula and shunting. And then we can use it for rigid bronchoscopy. I think that's twice in here, and electrophysiology. And on the right side, there are a couple of examples here. I mentioned the connection to our suspension laryngoscope. At the right lower side, you can see that an example for this. Very important. Avoid jet ventilation in obstructed airways. And this has not so much something to do with the inflow of the air, but most importantly, the outflow. So wherever you bring something in, you have to bring something out or have to bring it out again. And if you have an obstructed airway, what can happen is that you facilitate inspiration, but the passive expiration is hindered, and that leads to subsequent distension and potential bowel trauma of the lung and of all the structures that are distal to the obstruction. So if there's a severe airway obstruction, jet ventilation is usually contraindicated. There are a couple of variants. Overall, we basically distinguish supraglottic from subglottic airway obstruction. Jet ventilation. So supraglottic, there are a couple of devices to facilitate this versus subglottic, which basically means that the device is usually inserted through the glottis, like an endotracheal tube, for example, and then jet ventilation is conducted through that specific device. And then most importantly, for emergency situations or other more individual scenarios, you can also consider transtracheal, which in the end is basically a subglottic variant. And yeah, allows basically jet ventilation through any device or any needle that is inserted through the trachea. And that was what I mentioned before. If you carry it in, carry it out. So think about expiration and obstructed airways. Make sure that if you use jet ventilation, that expiration is still facilitated. So there are a couple of devices to facilitate supra and subglottic jet ventilation. So for example, for supraglottic jet ventilation, there are nasal tubes that, or nasal airways that basically look like a standard nasal airway, but have additional channels to allow jet ventilation. There are laser tubes, so standard classic ETT tubes that basically have jet ventilation channels. There's a Hansacker tube that I mentioned before. These are all subglottic variants. There are specific cannulas to facilitate transtracheal jet ventilation, so another subglottic variant that I mentioned. Very important, it's actually the three most common scenarios in our clinic. So either we really directly connected to the endotracheal tube, and this is clearly in a scenario where we have an otherwise healthy airway, but we do want to minimize the movement of diaphragmatic or supradiaphragmatic structures in the mediastinum for our catheter ablations. And then on the lower left, you can see a direct connection to a rigid bronchoscope. So jet ventilation can directly be connected to rigid bronchoscopy and facilitate basically ventilation while not using any other airway device other than the rigid bronchoscope. And that's the same for the suspension laryngoscope. So the lower left is for interventional pulmonology procedures. On the lower right, this is usually done in ENT procedures that often involve the larynx. As I said, in our institution, we conduct jet ventilation in a very high number of cases for catheter ablations. And these are all done due to atrial fibrillation. It's a very common disease. So over 60 million people worldwide suffer from atrial fibrillation. And there are a couple of studies that showed that actually catheter ablation is superior to just administering antiarrhythmic drugs. It's not perfect. We do see recurrences. We do see also failure of catheter ablation, but it is pretty evidence-based still. And what they do is they basically they ablate, so they induce scar tissue around the pulmonary veins. So the inlet of the pulmonary veins is a region that has been identified and plays a pathophysiological role in many patients, where basically these atrial fibrillation is usually induced or triggered. And when these areas are electrically isolated, that severely reduces the risk of subsequent atrial fibrillation. And these patients are usually in sinus rhythm and have intermittent AFib. And then post-procedural, the risk basically of recurrence is dramatically lower, but it's not zero. But you can already imagine if you're doing an intracardial ablation at this area and the heart is already moving a lot just through beating, the movements through gas exchange in the lung and inspiration and expiration can be quite substantial. And there are actually quite some data on this. So this is a retrospective study published in JACC, the Journal of the American Cardiology Association Clinical Electrophysiology issue. And they compared high-frequency jet ventilation versus conventional ventilation. And on the left side, you see basically the mean contact force. So the higher the force they need to facilitate contact with the myocardium, the more pressure they have to put on there. And you can see that if you only use high frequency jet ventilation, the contact force was severely reduced, which is better. And on the right side, you can also see that with high frequency jet ventilation, the recurrence rates, the arrhythmia-free survival rates were much higher. And so there is some clinical benefit to this, and it's actually I think, quite substantial that we can, as anesthesiologists, just by choosing a different procedure for mechanical ventilation, can contribute to the success rates just through improving the conditions in doing that procedure. So I am just going to move my image here a little bit out of the way. So as a result, and these are now data on the left side from our own institution, the use of high-frequency jet ventilation for these procedures has dramatically increased. And these are data that we analyzed for a publication that came out last year and was in an issue this year. So it's only until 2020, but I can tell you the data are basically looking very similar to 2020 until 2024. So you can see a dramatic increase on the left side in the use of jet ventilation for pulmonary vein isolations in our institution, whereas in 2013 we basically did maybe 10%. We're now doing almost 100% under jet ventilation. And on the right side, I want to show you that this is not just the case for our institution, but for example, a publication by Siva Sambhu and colleagues from Johns Hopkins is showing basically the same trend. So they use it utilizing jet ventilation almost 100% of the cases these days. So this is the protocol here at Beth Deaconess Medical Center. What we do is we intubate the patient with a standard ETT tube, ETT, or endotracheal tube, so 7.5 inner diameter for male patients, 7.0 for female patients often. And we establish conventional mechanical ventilation. We monitor baseline CO2 levels, and then the cardiologists, they facilitate access to the groins, and once they have access and the catheters in place, they start mapping. And just before they start mapping, we'll start jet ventilation. Doing jet ventilation, we usually draw a central venous blood gas analysis every 30 to 60 minutes to make sure we are not hypoventilating the patient, and this will be important. And I'm going to show you some data later. So we're monitoring the central venous CO2 levels. And then basically throughout the remainder of the procedure, we keep the patient on jet ventilation, which can be somewhere between 3 and sometimes 6 hours if it's difficult, although they have become pretty fast or much more efficient because we're just doing so many of these patients. But overall, the phase of jet ventilation is definitely a couple of hours. And then once the ablation is done and successfully completed, we convert to standard mechanical ventilation again. We get entitled CO2 readings again, so that's one important thing. Of course, doing jet ventilation, it's pretty impossible to get a decent or any meaningful entitled carbon dioxide CO2 readings. And then we let the patient wake up under conventional mechanical ventilation. The sheath are removed, and once they are removed, we extubate the patients. We're doing about 350 cases of these per year, and yeah, the median case duration is somewhere between 4 and 5 hours. We conducted some studies investigating also the immediate physiological impacts, especially in this patient collective. And I just brought you some images here. So these are electrical impedance tomography images. That is basically a technique that lets you in real time and on bedside monitor the distribution of ventilation or the distribution of gas in the patient's chest. So on the left side, you see basically a patient undergoing standard ventilation with a tidal volume of 7 cc's per kilogram ideal body weight, respiratory rate of 14. And then you're basically looking at it like you would look at a CT scan. So you have basically anterior and posterior, and what you see in the blue is a nice homogeneous ventilation of the lung. You can see how doing inspiration and expiration, you can see how the impedance in the patient's chest increases, and basically this represents tidal volume. And on the right side, you can see how this looks during jet ventilation. So this is completely chaotic. There's no real method to the madness here. You can see that there are all these effects in place. So sometimes one lung area is involved in ventilation, then again not. So I think it's much more chaotic, and it's not as controlled, and it's very hard to predict which areas of the lung will be recruited and won't be recruited at any given time. So of course, it poses some challenges. Some of the potential complications that are really rare is, for example, barotrauma, emphysema, pneumothorax, dry gas injury. So that's one really important thing to keep the if the patient's undergoing or if you're administering jet ventilation for more than an hour, although there's no clear cutoff, the jet ventilator should really humidify the gas. Otherwise, there will be injuries to the airways just because due to the repetitive administration of dry inspiratory gas, and then the dried out trachea gets inflammation and risk of perforation and other things. What is a little bit more often is hypo or hyperventilation. Again, we cannot measure end-tidal CO2 during jet ventilation, and another problem is that during once the mapping is conducted or is done in the for the pulmonary vein isolation, we need to maintain the same movement in the chest. That means we cannot really alter the parameters for jet ventilation. So we have to really make sure that the initial settings we are setting in the jet ventilator really is what the patient needs to maintain regular gas exchange and also decarboxylation. And we see hypo and hyperventilation quite a lot, and I'll show you some data. So this is what I was talking about. There was a publication that just got out in a print issue, was published last year online. So this is basically the number of patients that we saw. So we analyzed about 1,000 patients undergoing jet ventilation at our institution. And these are the proportion of patients that had at least one blood gas analysis above or below a certain cut point. And you can see that roughly like a little less than half had a PCO2 of more than 45 or below 35. So that was quite substantial that we saw a lot of patients with either hypo or hyperventilation. That was also reflected in the corresponding pH. So those were respiratory alkalosis or acidosis in those cases. And you can see that the acidosis was a little bit more common. So pH below 7.35 was present in about 45% of our patients. That translated in increased risk of hypocarbia. So what we did was we compared high frequency jet ventilation, here HFJV termed, with conventional mechanical ventilation, so CMV. And you could see that the risk for hypocarbia, but also for intraprocedural hypotension was significantly increased. That was adjusted for a couple of confounding factors, including patient and procedural characteristics and comorbidities. So that's one of the problems that we are facing. So we are hyperventilating a lot of our patients when they undergo jet ventilation. Hypotension is an issue, and that actually has been also documented in other studies, probably due to right ventricular impairment and impairment in outflow of the right ventricle, that these patients also have a higher risk for hypertension. Overall, there was a promising outcome of the studies. Jet ventilation prolonged the recovery time measured as readiness discharge or discharge to PECU from PECU by about 38 minutes. That might not sound substantial, but at a medium PECU length of stay at about 1 to 2 hours, it's actually quite long. And then again, binds resources and so on. So even though we know that jet ventilation in these procedures is probably associated with better outcomes for the patients, the intraprocedural complications are higher with jet ventilation. And I think that's something we need to address as anesthesiologists and establish better protocols. And what we did was we predicted hypocarbia and hypercarbia based on the patient's respiratory system compliance. And you can, what this figure basically shows is that there's an almost linear relationship with patients' compliance. So patients with a very poor compliance on the left side are at much higher risk of hypocarbia, just because their tidal volumes will be less at the same jet ventilator settings. And patients at risk of or with a very high compliance will be at higher risk of hypocarbia, just because they will they'll have higher tidal volumes at the same jet ventilator settings and therefore higher minute ventilation. And this speaks to the fact that it's actually really important to individualize your jet ventilator settings. You cannot use the same setting for every patient. And of course, we're still working on giving exact recommendations for each patient. It sometimes really depends. but it is important to fine-tune some of the settings. What you can also do, and what we have established, is transcutaneous CO2 measurements. So since we are unable to measure end-tidal CO2, there are devices available that can measure this transcutaneously. Sorry, oops, going back. And these have been validated in clinical routine. They sometimes give absolute values that don't always reflect the PA CO2 or the end-tidal CO2, although actually if you look at the correlation plots here, they're pretty close to baseline. What's a little bit, or what's much more actually, and it's not depicted here, what's much more reliant is the trend. So what we usually do is we establish mechanical ventilation based on our protocol. So standard mechanical ventilation, measure end-tidal CO2, at the same time measure the transcutaneous CO2, and then we see the offset. And then we're trying just to maintain the same transcutaneous CO2 throughout, even though if there's an offset of 10 or even 20 is millimeters of mercury, it doesn't really matter as long as the trend is maintained. So that's one option to ensure that the patient is not getting hypercarbonic. The other one is really fine-tuning your settings. So this is our current jet ventilator. We are using, or we're giving recommendations for driving pressures between 18 and 24 millibars. This is one of the most central parameter to dial in. So the driving pressure is basically what drives the ventilation and subsequently sets the tidal volume and during jet ventilation. Historically, we have the recommendations were more like in the 24 millibars range. And I think that this was what drove a lot of the hypocarbia events that we saw in our study. And we've become more conservative. And also we widened the range. So really like for 18 on the lower end, we are, and I'm going to talk about this on the next slide, we're really recommending like 18 to 20 for swimmer patients with a higher respiratory system compliance, and the higher end, about 24 millibars, should be reserved for very obese patients. The frequency is between 80 and 120 per minute, although I think 100 to 120 is the most common frequency that's dialed in. FiO2 between 80 and 100, and for longer procedures that exceed an hour, we use humidification. So to go a little bit more into details, driving pressures, one approach would be to start at 20, and then very important to remember that the jet ventilator doesn't generate the driving pressure actively. Basically, it's connected to a high flow or high pressure gas inlet, and it interrupts the continuous gas flow, which then allows for a reduction of the output pressure. It can be increased to 40 psi, but this is already pretty high. And what we really recommend is titrate it to PaCO2 if we can measure this. If not, then maybe transcutaneous CO2 might be an option. For very short procedures, like some of our pulmonology procedures that are sometimes just half an hour, that doesn't always play a clinical role. But we do see still a lot of hypo and hypercarbia, and we have shown in subsequent studies that especially hypocarbia is associated, for example, with increased risk of patients' delirium. So that has some clinical implications. Respiratory rates, if you look into the literature, they even vary between about 80 and 100 or 90 and 150 breaths per minute. Clinically, what we use is between 100 and 120. The respiratory rate here is inversely proportional to tidal volume, of course. So if you're always delivering the same driving pressure and you increase the respiratory rate, you will decrease your tidal volume. So if you want to increase the gas exchange, the respiratory rate isn't always an ideal measure to do this, because it's very hard to predict the effect on minute ventilation if you change the respiratory rate. It's much better to just change the driving pressure, then you will always know what the effect on tidal volume is. So if you increase the driving pressure, you always have a higher tidal volume. If you decrease the driving pressure on jet ventilation, you always have a lower tidal volume. If you change the respiratory rate, it can go either way. So even if you increase your respiratory rate, you will decrease your tidal volume, and thereby you might not actually increase gas elimination. You might even get paradoxical effects. And also at higher respiratory rates, the of course, the time for expiration becomes much more shorter, so there's an increased risk for airway trapping and basically intrinsic PEEP. The FiO2 on jet ventilation, actually, there shouldn't be any concern to even use 1.0 unless you have any cautery in the airways, which can sometimes be in our interventional pulmonology procedures. But the FiO2 can be set at 100% or high levels because of the Venturi effect, which will entrap, and that's what I said before, will entrap air from basically from surrounding air, and then mix this, and you will facilitate an FiO2 that is much less than what you said. So overall, as considerations, patients undergoing jet ventilation usually need deep sedation, also because there is return of spontaneous breathing, CO2 levels might rise, and if you don't want the patient to move, you should facilitate deep sedation. Consider topicalization of the trachea, or more importantly, even humidification for longer periods of jet ventilation. All of our jet ventilation patients receive neuromuscular blockade. We do tolerate that it weans off, so it's still, especially towards the end of our EP procedures or our catheter ablation procedures, NMBAs have usually weaned off, and we don't see any larger problems with this. But you will, of course, reduce the compliance of the respiratory system when there's no paralysis present, so the risk of hypoventilation increases as the NMBAs wear off. Initially, they all get neuromuscular blockade. Since it's an open system, it's impossible to deliver, at least at this time, to deliver volatile anesthetics. So all these patients receive a total intravenous anesthesia. We use propofol and remifentanil for almost all of them. And then because of this and the combination of neuromuscular blockade in our clinic, we also use process EEG monitoring to just monitor and document depth of anesthesia. So in summary, high-frequency jet ventilation is a really helpful tool for a selected group of procedures, but those are quite a bit, and it's not just a minority phenomenon in our clinic, but we actually use it every day, and all of our anesthesia providers are trained to use it. For example, for lower and upper airway seizures, for surgery, for complex ENT procedures, interventional pulmonology is certainly one of the areas where we use it the most, and then also atrial fibrillation procedures, especially if you have a very productive electrophysiological department and cardiologists, this can be really helpful. And if you're not using it in these procedures yet, your cardiologist at some point might actually ask for it. It can be life-saving and can't intubate, can't oxygenate situations due to the limitation and time. I'm not going to talk about this now, and this could easily fill up another whole lecture. And then very important, adjust ventilator settings, ideally individualize at least your driving pressure for the jet ventilation. And consider alternative monitoring when end-tidal CO2 is absent, such as transcutaneous CO2. That was it from my side, and thank you so much for listening. Please reach out to me individually. Also, if you have more questions or want to discuss something. And other than that, thank you so much for having me here, and I'm going to stop the recording now.